Community mental health requirements for assisted outpatient treatment, presented by Sojourner Jones, Detroit Wayne Integrated Health Network, Community and Law Enforcement Liaison. This training is presented as part of the Michigan Assisted Outpatient Treatment Toolkit. To learn more, please visit behaviorhealthjustice.wayne.edu/AOT. Overview of assisted outpatient treatments, also known as AOT. It is an evidence-based tool that promotes recovery, reduces harmful behavior, lowers hospitalization and emergency room use, as well as reducing costs. In addition, it's all part of the Mental Health Code, particularly statutes 330.1455, 330.1474, 330.1475. So what it is the basic to get those persons who we know that suffer from a mental illness, who sometimes, most often than not, do not follow up with treatment upon discharge from an inpatient setting. There are 3 types of assisted outpatient treatment orders. Hospitalization. The initial duration is 60 days, but it can be ordered up to 1 year. A combined initial order, meaning that there's a 60-day inpatient and 180 days in the community. And then there's outpatient only, which are filed in the community, and that is for up to 180 days. Please be aware of these days. Orders are reviewed every 6 months. So that's why I say pay attention to the days, because they will come up very quickly and you'll look and you have a report that's due to the court and you get lost because the days come up very, very quickly, especially for those combined orders. As the member gets closer to the expiration date of their initial order and you want to continue that treatment momentum, and so it'll be in the member's best interest to file a continuation order. A second order must be filed within around 15 days of the original expiration date of the 180-day initial order. What does the law mean for community mental health agencies? Community mental health agency is now the responsible party for engaging these members in treatment outside of an inpatient setting. So at any time, a community mental health provider can do a warm handoff, meaning that the person get discharged from an inpatient setting and go directly to their CMH provider. Coordination of that discharge prior to the member being discharged from the hospital, meaning you have those conversations with the inpatient settings. You try to find out what current treatment modalities the member may be on and any other obstacles that the hospital may be able to tell you, such as substance abuse, etc., to be able to address this member more so when the member come home. Also, it gives you an opportunity to develop that rapport with the member. Most members who are on an assisted outpatient treatment order do not engage with services in the community. And so it is very important to develop that rapport with the member as soon as possible. Remember, treatment takes place in the community. Members get stabilized in an inpatient setting so that we can do that warm handoff to begin to continue them on their treatment journey. Assisted outpatient treatment services is the responsibility of the CMH. It does not matter if the member was ever referred to the CMH provider and never followed up with their intake appointment, or have had several no-shows, or if the member's case is closed due to non-attendance or compliance. It does not matter. The CMH is still responsible for service delivery. And so it is very, very important that you are aware that the member is yours, meaning that they've been to you in the past, they've dropped off, they've showed back up, they dropped off, the case is closed, tag, you're it. Unless the member requests a CMH change. If that's the case, then the necessary paperwork within your entity to change the member CMH provider is completed, and you still do a warm handoff from your services to the member's new services, because court order follows the member. It doesn't matter where the member go for CMH services. They can go all the way up to Flint, Michigan, or Marquette, it does not matter. The order follows the member. However, we're going to continue that continuity of care and ensure that the new CMH provider know what is taking place at your entity so that the services can continue without interruption. The sooner the member is engaged and reconnected, the more successful the member will be with their AOT order. Services available while a member is on assisted outpatient treatment order. Services can range from case management, medication, including long-acting injectables and med drop, any kind of lab test to determine medication compliancy efficacy, outpatient therapy, individual and or group, day or partial day programs, educational or vocational training, supervised living, and that doesn't only include adult foster care. It can be in a more highly structured as long as there's someone there to monitor them. Assertive community treatment teams, with the exception of those members that's in supervised living. As you do testing and or treatment, this is really, really popular and is needed for our co-occurring members who have both a mental illness and a substance abuse. Even though we know substance abuse treatment is voluntary, if we can begin to get the member to at least talk about going into treatment, then that's a step in the right direction. And then there's the other section. Whatever other services you could possibly think of that this member may need so that they can become successful in the community and adhere to their treatment, and to prevent any form of relapse or deterioration of the individual's mental health, that can be added at that time. I often encourage hospitals, CMH providers, at any point in time, whatever you can think of, put it on the order. We go by the adage, we'd rather have it and not use it than use it and not have it. Considerations for those members who are on an AOT. Make sure that the member understands that they are on a court order and what that means. Oftentimes, our members come into an inpatient setting in crisis, get stabilized, and because they're stabilized, they're ready to go back out in the community. And they sign pretty much anything we put in front of them, and they have no knowledge or understanding of what they're signing. Please take the time and do the due diligence to at least explain to our members what this means, because the court order follows the member. It's not just for the hospital, it's just not for the CMH, it is for the member. Also, please consider whatever wraparound services that the member may need. If you know that housing insecurity is a big issue for the member, please check supervised housing. That way we can make sure that we can get the member in his whole totality of services so that he will have a less chance of falling through the cracks. Med drop is another opportunity to have the member's medication dropped off directly to wherever address they give us, so that they don't have to worry about going to the pharmacist or whatever copays may happen or whatever. The med drop comes directly to the member's household. And so it's a convenient tool. Again, we're trying to alleviate barriers for our members to receive the treatment that they need. Long-acting injectables are considered best practice for members who are on assisted outpatient treatment. So have those conversations about the long-acting injectable. Talk about the pros that comes along with long-acting injectables. Fewer side effects. You don't have the stigma of being reminded to take an actual pill. Third-party monitoring and communication with probate court. It is so important that you keep the court abreast of what's going on with the member, good and or bad. So there is the form Notify Court of Noncompliance, PCM 230, that assists you with that. All of probate court and all of within the state of Michigan, no matter what county, we all use the same forms. And then also best practice. You have to have a dedicated staff. We understand that staff shortages are high within the United States. And so the staff that you have, make sure that they know the members, that they have time management, because yes, with court orders, it does come with a lot of paperwork. So make sure you're trying to have that connection with your staff and the member. And then we have to still include our guardians, are they as they are the decision makers for majority of our members, especially when it comes to signing authorizations and for enrolling them in CMH services in the community. So, who is considered the best candidate for assisted outpatient treatment? I know historically, most of your inpatient settings has used AOT for treatment compliance while the member is in the hospital. However, now with the enforcement of the statute, we have to take in consideration who's best fit. And so some of the recommendations are that ALTs work best for individuals who are younger versus older, um, meaning the newer onset of their mental illness versus those who've had it for years and years and years and know our system. Emerging evidence that ALT shortly after an onset of severely and persistently mental illness works best for the overall effect. For those members who are living with a psychotic disorder, examples of schizophrenia or schizoaffective disorder, they work best for. Those who have a lack of awareness and or insight of the need for treatment to be able to assist them with their future of their mental illness, meaning that they don't think they have a mental illness, they don't need this service, and that they can do just fine without it. Also, those who don't have drug allergies to antipsychotics that's available in the long-acting injectable formularies. And then those who have some life skills to sustain housing and employment. Yes, they can be house servers, but that's only because they may not have anybody to assist them with filling out a rent application. They have resources, meaning they have the money, but they just need some additional case management services. They have employment, but due to their lack of understanding that they even have a mental illness, they're not taking their medication. And so therefore they're on this rapid roller coaster of inpatient, employment, etc. So we want to take those considerations for who's best for the candidate for AOT, because we want the member to have the most success. So again, that's the importance of having the conversation with the member regarding the court order. Again, these are best candidates. They are recommendations. They're not etched in stone. We understand that some members and the hospital may feel that the member may really benefit, even the member's family. And so, not to say they can't be recommended, but these are just the best candidates that we've seen in a CMH setting that get the most benefit from it. So within the ALT field, there are some clinicians who work out better than others. This is just a recommendation that we have for who's the best clinician to work with members on an ALT. The clinician must have some training in crisis. Crisis is how these members operate, unfortunately. So we're trying to change that cycle. And most clinicians who have that crisis training, who can think on their feet, who have those resources at their hand, are considered the best. Those clinicians who are seasoned within this field, but aren't conditioned to the fast pace of getting the member in, getting the member seen, and then that's it. Clinicians who have those critical thinking and deductive reasoning skills, being able to think on your feet, be able to play the game of chess, not checkers, being able to think what the member may need, even if the member hasn't said anything at this point in time. Those clinicians who have thick skin, we know that our members are going to cuss you out, call you outside your name, and it's nothing personal. It's just that that's who's there at that time. So you need some clinicians who have that thick skin and also who's knowledgeable of the resources in the community. It is very, very important for this population because they need all of it. And those members who can, those clinicians who can think outside of the box. You know, where can my member go if they need an identification? Where can my member go if something is wrong with their social security or if they want to change their CMH provider, et cetera, et cetera. You need to just be able to have those resources on hand and be able to call them at the drop of a hand. Also, there are those clinicians who love difficult cases. AOTs are a little bit difficult because they are different. And so if you know you have those clinicians who like working with those populations, their best. Also, those who are willing to testify and not afraid of the court. I know during my education, I never took a course on court hearings or how to present in court. But with the assisted outpatient treatment order, there's very a possibility that you will present in the court. And so when you present in the court, you have to look a certain way. You have to know your facts. And so you need to have a clinician who's willing to do that. Um, if they have some background in criminal justice, working with law enforcement, working with the courts, that's also a plus. Also, those clinicians who are able to connect with the member. For some reason, you have that clinician who, whenever a member sees them, they light up. Nothing special, it's just who they are. And so you want to grab those clinicians as well. And then you need a good team player, someone who can play well with others in the sandbox. Those are the clinicians that work best with this population. AOT is about the member. If there's one thing that I would like for CMH providers to understand and know, is that it gives us a wonderful opportunity to connect with our members who don't think they need treatment, who even we know after years and years and years, or even if it's just the beginning of their onset of their mental illness, that they know that someone cares about them and we're willing to go the extra mile. Yes, we know they don't show up for their intake appointments. And so even though we do the 3 calls and no one answered, we don't close the case. Yes, we know they're not going to show up for their initial intake appointment. We send them a letter in the mail. We don't close the case. We try to engage that member at all costs and teach them, empower them, and educate them of how their life could be if they were compliant with their mental health treatment. And so that's the beauty of an AOT. We get to go above and beyond to reconnect, re-engage, educate, and empower our members.